So today we talk about understanding labor pain, CTG, and the fetus. So we start from the background of the fact that when you're in labor, we have oxytocin, which is acting on the uterus and causing contractions. However, there's a significant difference between endogenous oxytocin and the syntocinon or synthetic oxytocin that we use. Endogenous oxytocin reduces stress and pain because it works centrally. However, syntocinon administered intravenously does not cross the blood-brain barrier in significant amounts. So this central effect is lost. So the analgesic and psychological effects that the mother has with endogenous syntocinon does not come with the synthetic oxytocin. So we know that the labor may be more painful and the mother may be more stressed. But there are a couple of responses that the mother has to pain, which feeds into how the baby also responds. The commonest one is hyperventilation. You know that when the mother is in pain, there's a lot of fast breathing. And when she does this, she's blowing off a lot of carbon dioxide. The partial pressure of carbon dioxide therefore drops and she develops a respiratory alkalosis because her pH will therefore rise from the loss in H+. This will cause a left shift in the oxygen dissociation curve and therefore will cause an increased affinity to oxygen and a decreased release of oxygen. And this will mean that oxygen exchange at the placental bed will be impaired with hyperventilation. And we need to understand this in the context of the fetus because the fetal lung is the maternal placenta. And therefore, if oxygen across that pathway is impaired, then fetal oxygenation is going to be impaired as well. When you have respiratory alkalosis, you have a compensatory metabolic acidosis, and this will happen in the mother because she'll start using her kidneys and excreting more bicarbonates to try and lower the pH. However, in the context of labor, you realize that she's progressively contracting, requiring a lot of metabolic activity, a lot of energy. Her oxygen is impaired. And therefore, as this goes on, she also begins to build acids. And therefore, there's a worsening of metabolic acidosis. And once maternal pH starts to drop, it reflects in the fetus. So fetal pH also starts to drop. We know that the one thing that is really toxic to the baby is H+. And therefore, as there's accumulation of H+ in fetal circulation, it becomes toxic to the fetus. In between the contractions, when she stops hyperventilating, she is not even breathing in properly. So there's hypoventilation between contractions. And this also worsens the problem because there's hemoglobin desaturation from impaired oxygenation within these periods. So the whole oxygen exchange mechanism during labor, painful labor, is quite impaired. But we should understand that the baby lives, as we've seen from previous lectures, in a milieu of 30 to 70% oxygen. And most healthy babies are able to adjust well with no problems. The issue comes when there's an already compromised baby. Because of the stress, pain, and anxiety, the mother releases a lot of catecholamines. So normally she releases epinephrine and norepinephrine. And what these does is that they inhibit uterine contractions and prolonged labor. The inhibition of uterine contractions and prolongation of labor is through the beta-adrenergic activity on the uterus. There's also vasoconstriction and reduction in blood flow from alpha-adrenergic activity, mainly from norepinephrine. So you realize that this mechanism impairs labor, prolongs labor, and also reduces blood flow. Prolongation of labor is not really in the best interest of the baby because baby has finite reserves. And reduced blood flow also means reduced oxygenation and reduced fetal oxygenation. The catecholamines also cause the secretion of glucagon and cortisol, which are all diabetogenic hormones, and therefore there's hyperglycemia. They also inhibit maternal insulin use. So you are producing a lot of sugars, you have hyperglycemia, but you're unable to use it. So you are dumping a lot of sugars into the baby. The baby has to respond with a hyperinsulinemia because the insulin isn't crossing to follow these sugars, and increased metabolic activity in a milieu where the baby is already oxygen deprived. So this will further stress the baby. Hyperlactatemia will occur because when you start stimulating these hormones, you stimulate glycolysis, you produce pyruvate. But in a low oxygen milieu in the mother, she'll go more into Cori cycle, produce lactate. Lactates in Cori cycle will be used to produce more oxygen, more glucose. Sorry, this glucose produced is very expensive because you're using 6 ATPs to produce this glucose, and you're just going to get 2 ATPs out of it. So this sort of depletes the mother further. So from all that we've described, you realize that the pain in labor can also be expensive to the baby. We've spoken about hyperventilation. We've spoken about cortical amines. We've spoken about hypoventilation. We've spoken about respiratory alkalosis and the compensatory metabolic acidosis, which all have effects on the baby. And we've also spoken about hyperglycemia and hyperlactatemia. Now, what does labor analgesia also do? We have long held misconceptions about labor analgesia. There's a belief that unmodified labor is harmless because pharmacological forms of analgesia must have adverse effects. We also have a long held belief, which even though is disproven, is still held, that epidural analgesia, which is the most invasive form of pain relief, must be more damaging to the fetus. And of course, there's also a long held belief that pethidine given during the last periods of labor will cause more neonatal depression than when it's given earlier in labor. And we'll disprove a lot of these misconceptions as we go forward. So pethidine, we know, inhibits fetal movement, muscle activity, oxygen saturation, and variability. They are all reduced by pethidine. So this we will see in the physiology and we'll see on the CTG trace. Even though the popular belief is that pethidine given in the last hour of labor will cause neonatal depression, research shows that the worst happens if pethidine is given repeatedly and given 3 hours or more before delivery. And you have the least respiratory depression when pethidine is given only within the last hour. So this sort of goes against conventional wisdom, but that is what the research says. That is what is quoted in research articles. The respiratory and metabolic acidosis were more severe with pethidine than placebo, and that is to be expected. And the incidence of acidosis is higher when pethidine is given 5 hours before birth. And all of this is due to the norpethidine, which is a long-acting active metabolite. So the longer you expose, the more repeatedly you expose to pethidine, the more effect you have in terms of neonatal depression. All the effects, however, can be reversed with naloxone. Some labor units will use diamorphine, where some will give 5, 7.5, or 10 milligrams diamorphine, normally repeating it about 3 times, 4 hours apart. And when you compare diamorphine to pethidine, it has slightly better analgesia and fewer low upgas. However, other research has shown that babies on diamorphine may need more resuscitation. So we can see these effects. And when you put babies on pethidine or diamorphine, what you see on the CTG is reduced variability. And it's a combination of reduced fetal movement and central sedation on the baby. But we know also from the research that there's acidosis associated with these medications. And therefore, you have to be careful and vigilant when you put babies on these opioids. We can also give epidural, which helps in labor and is very effective labor analgesia. It does not affect the first stage of labor. It prolongs the second stage of labor, but just by about 14 minutes. There's increased risk of instrumental delivery, but no change in CS requirements. And the timing of giving it doesn't really matter. Now, what are some of the benefits of giving this? There's reduced maternal stress. When you reduce maternal stress, then you will not have the catecholamines being produced. And these catecholamines will impair labor and therefore prolong labor, reduce blood flow, as we've seen. They also cause hyperglycemia, which is dumped into the fetus and may be detrimental to the fetus. Hyperlactatemia, which is also dumped into the fetus and may be detrimental to the fetus. So reduce all this. You also reduce pain and reduce hyperventilation, and therefore there's better oxygenation. There's uterine vasodilation, better blood flow, better oxygenation for the baby. there's fewer episodes of hypoventilation and HB saturation. So again, better ventilation. And you don't have the direct opioid effects that you would have with the pethidine and diamorphine. However, there's vascular instability with these medications, and you can have hypotension. You can also have fevers from epidural, and we'll talk about this. Increased need for oxytocin, prolonged second stage and instrumental deliveries, which may all affect the CTG and affect the fetus. We know that epidural is associated with an increased risk of fever. A research natural experiment study compared epidural use in the same unit before they had access to epidural and after access to epidural. And they realized that there's a 3-fold increase in temperature above 37.5, 18-fold increase in temperature above 38. Again, there's a subset of women who develop this fever, and those who develop this fever develop it within about an hour of the epidural. And there's also thinking about how this occurs. We think it may be due to altered thermoregulation. It may also be due to the less heat dissipating effects of hyperventilation, which is now gone with epidural, and a form of inflammatory response by elevated interleukins from epidural. What are the maternal consequences? Because we've given epidural and there's a fever, we'll normally respond to this fever by treating on the sepsis pathway and starting antibiotics. And we also know that there's an increased risk of operative vaginal delivery with epidural. There's no epidural directly does not affect the CS rate, but then if there's fever and there's concerns about what the fever may do to the baby, then there's an increased risk in operative delivery like cesarean section. Again, fetal fever is directly responsible because we know that fetal fever is associated with cerebral palsy because of the effects of the fever itself, not even the sepsis or chorioamnionitis related to the fever. So when there is fever, we need to respond with IV paracetamol to try and reduce it. So this is another non-hypoxic pathway of injury, and therefore fever can cause a rise in baseline on the CTG. We also know that when we give epidural and all forms of neuraxial analgesia, it's a reduction in epinephrine, but there is no effect on norepinephrine. Epinephrine works more on the beta receptors, which cause relaxation, but norepinephrine works on the alpha receptors that cause uterine artery vasoconstriction. So this effect is more profound with combined spinal epidurals, where there's rapid onset analgesia, and therefore you are cutting off the relaxation effects of epinephrine and having more norepinephrine, and we can have sustained vasoconstriction in the placental and uterine bed. This can cause an acute bradycardia, and theoretically, given drugs like ephedrine can help restore fetal heart rate. And this is very important when you are taking a pathological CTG to theater to do a trial of labor. Once you give it, there can be sustained bradycardia, and if the baby is already compromised, you see this. So this is an example of an already pathological trace where an epidural was given, and after the epidural, there's acute bradycardia, and this is to be expected from what we've discussed so far. So overall, we know that pain in itself when the mother has effects on the baby. And we know that the analgesia that we give for the pain may also have positive and negative effects of the baby. And understanding this in interpreting CTG and managing labor is very important. Thank you.